I'm Dr. Monika Kaushal. I'm a consultant neonatologist and head of the Department of Pediatric and Neonatology in Emirates Specialty Hospital. Along with that, I'm also running my I'm medical director of the same hospital. So I have a long journey starting from India. Like I did my MD from PGI and DM from All India Institute of Medical Sciences. Then I did a fellowship in UK and a diploma in UK. And I'm here in UAE past now almost 18 years. So started a small from a small four bedded to 14 bedded NICU level 3 and also we had started some fellowship programs also for some time, and that's my introduction. So I mean we are taking care of all sick neonates starting from 23 weekers and above. So as you see that, if you look at the data, then, 3% of the babies who are born would have jaundice. And so the issue is that uh, we, it's not too much, but it's not rare as well. And the babies normally would have some amount of jaundice, which is also required by their body, which is called physiological jaundice. Having said that, we don't know which baby might, that physiological jaundice itself might go to a level which may cause problems to these babies. And there comes the role of a doctor to be sure that, you don't miss those babies with jaundice. And the issue is that we can't keep the jaundice actually starts from days 2. Usually, if it is physiological, pathological may start early on day 1 itself, and it may increase till day 7. So, we can't keep our babies in the hospital for so long. So, there has to be some way to see that we don't miss the babies who might develop a higher jaundice and require your attention and require some treatment. And at the same time, we are able to discharge them properly. So, what we have in place is we have our screening protocols in place where we also screen the baby when the baby is at in the hospital, and even before we discharge, to see where the baby would lie. If it is a high risk, to call them early, or if it is a very high risk, then don't discharge them and keep them. And so there are clinical parameters which we look at, and also we have a transcutaneous bilirubinometer which we keep checking the jaundice levels transcutaneously and plot it in our specific bilirubinometer charts to see where they fall. So if they are, we categorize them into low intermediate, intermediate, high intermediate, and high risk. And depending on where they fall, we will call them accordingly so that we don't miss them. One of the clinical risk factor is the feeding, because if the baby is not fed well, he's not passing enough stool and urine, the jaundice goes higher, and that's the basic thing which we are telling, especially the primary mother. Because the primary mother doesn't have an experience, so we have to be giving an extra attention to her to make her aware how frequently the breastfeeding should be done and how she monitors that breastfeeding is adequate or not, to look at the urine. If the baby should pass around 6 times urine in 24 hours. The color of the urine is also very important, which should not be very dark yellow or a pinkish, which means there is a concentrated urine and the feeding is less. And the amount of stool is also important. So this is one of the risk factors when the babies are not fed well, or they may come back with higher levels of jaundice, which is very important. And then the other risk factors, of course, are the blood group incompatibilities, where, like, if the mother is Rh negative and the baby is Rh positive, the baby may have a higher chance of jaundice because of the hemolysis which will go on. And also is there is a ABO incompatibility where the mother is O positive and the baby is not O, then also there are chances of hemolysis and baby coming back with the jaundice. The other risk factors are G6PD, which is very common in some of the areas like northern and some areas in particular countries. And so, if you have a family history, you will know them, and then they will be put into high risk categories. Some of the places where it is really high, people are doing this G6PD right before the discharge, so that you know that you are discharging a baby who is not G6PD positive. And then there are other risk factors because there are too many, like if it is a smaller baby, if the gestation is smaller, um, then these babies might have a higher risk of developing a jaundice, and baby is sicker or baby gets infection, then also the chances of jaundice goes higher. So apart from them, actually there's a big list of risk factors which we look at, and then we give scoring. Depending on that, we say this becomes a clinically high risk baby, so that we take an extra care and call them a bit earlier. To begin with, I said that because we can't keep the babies in the hospital just to for monitoring purpose for a very long time. Logistically, it is not going to be feasible, and hence what we do is that, as I said, we will we will be monitoring them with the transcutaneous bilirubinometer, and if the and we will plot them. In case this transcutaneous bilirubinometer value is itself little higher, we will cross check with the blood levels, and then we see whether and we see the other clinical parameters, as I told you, the breastfeeding, low birth weight, and how much is the gestational age, any ABO incompatibility, RH incompatibility, all those risk factors we will see. And then we will plot whether the baby will come into low intermediate or higher intermediate or high risk categories. Depending on that, we might call them, like if it's a high risk category, we may even keep them or may call within 12 to 24 hours. If it is a intermediate risk category, we'll call them between 24 to 48 hours, and if it is low, then we may call it at 72 hours. So depending on where they fall into, what risk factors they have, we have to call them, and we have to make sure that we call them. So what we have prepared with us is jaundice recognition and pamphlets. So we give to every mother, and we plot them and say that here where your baby is uh, following, and you have to take these precautions. And the precautions are that we should be talking to them, that you should be feeding them every 2 to 3 hourly. We should monitor They should be monitoring the baby's urine and stool, and also they have to monitor the baby's activity. If the baby is too lethargic or excessively crying, not accepting feeds, then they have to return earlier. It's very difficult for the mothers to understand the jaundice, and we might actually clinically, when they look at, we do actually explain them that if the baby looks yellow, and how the yellow progresses, first it comes on the face, then it is on the chest, then abdomen, then the legs, and down. But sometimes, it becomes very difficult for the mothers to actually pick it up, and we cannot just rely absolutely on that. So we do explain that, and we give the pamphlets, and explain to the mother, and tell them to take these precautions and return to the emergency if they find any of these parameters going not okay. However, we do give them follow-up appointments depending on what is their discharge criteria, and we give them a reminder that your appointment is due telephonically and from with SMS messages, so that they don't forget. And if they don't come, we even call them up to ask uh, the status of the baby, because it's if a baby gets a jaundice level which is very high, and the baby's brain gets affected, and we get a connectress, that is brain damage because of the bilirubin. It's a very like sad situation, and it is a very preventive situation. So we have to take all the efforts to prevent it. First of all, whenever we start a phototherapy, the mother, most many mothers start crying because they are now, because this is not a one day old baby, so they are already attached to the baby. They are used to the baby being with them. So we have to be taking away the baby and putting them in the phototherapy. So that is a very emotional kind of situation. I, in my practice, try to keep phototherapy unit inside the mother's room itself, so that there is no like bonding issues between the mother and the baby. And only when the jaundice levels are so high that we have chance that it may affect the baby's brain, and it is near the exchange level, then that is the time when we are actually separating the mother and the baby and putting the baby in the NICU. So otherwise my babies are with the mothers. So this is one thing. So when we are starting a phototherapy, we have to tell the mother also, and the nurse needs to be knowing what things are to be monitored for the baby, because we have to open all the clothes of the baby and the baby is naked. So two things can happen: either the baby may become hypothermic, that is the baby may turn cold, or it may become hyperthermia because of the too much of heat generated in the machine, especially because we are using the round 360-degree machine if the jaundice is very high, to bring the jaundice level quite fast. So then the heat generated inside might be an issue. So this is to be seen. So that there, here comes the issue of temperature maintenance. So we some of the phototherapy units do have temperature maintenance system, and otherwise we clinically have to look into the temperature of the baby off and on. And we have to instruct the nurse as well as the mother that if the temperature goes higher, we have to open the door, or if the temperature goes lower of the baby, then we need to rewarm the baby and heat the thing and then put the baby back on the phototherapy machine. So the other issue which is there is that the lights which we are using in the phototherapy machines to break the bilirubin from the skin, these lights sometimes may be not okay for certain parts of our baby's body, like the eyes and the male genitalia. We don't have enough studies, and we can't afford to do these kind of studies to see if there is a toxicity happening or not. So that's why we continue to follow this, and we use eye band on the baby's eyes to cover the baby's eyes, so that the eyes retina is not affected by this phototherapy machine, the light. So these bands are actually should be chosen according to the weight of the baby, because they are of different sizes. So it should be in such a band that it should not keep coming out. At the same time, it should not be pressing the nose to make the baby not to be able to breathe. So that size should be appropriately chosen, and it should be appropriately put on the baby's eye. And the mother also has to be taught how to put these eye bands onto the baby, and to keep an eye, because nurse cannot, when the baby is with the mother, nurse cannot keep entering the room quite often. She will be coming 2 to 4 hourly, but 24 hours baby is with the mother. So mother has to be instructed as well. And we believe in family centered care, where the mothers get involved in the care of the babies, which gives a better care, and she feels empowered to take care of the baby. So I band is one of the thing which needs to be put. And I would say that when the mother has to breastfeed the baby, when the baby has to come out of the machine, she should remove the eye band, so that there should be an eye contact between the mother and the baby, and that time should be taken for the bonding of the mother and the baby. The second thing, and she should not forget to put it back once she puts the baby back into the phototherapy machine. The second thing, which is these lights might be toxic, is the genitalia, especially the male babies, the testicular part. So we do cover and we keep putting the diapers in. We know that the surface area of the baby should be maximally exposed for the phototherapy machine to get a benefit of phototherapy, but this part we do cover with the diaper, and it's quite acceptable that it's still the phototherapy works very well. So this is another thing which these are the two things which we have to take care. The other small side effects are like some rashes may come in, which we have to also tell much before, because if you don't prepare your mothers, they will have quite apprehension, and they may go into anxiety and things. So tell them before that, so that they know, okay, rash is going to come. So tell them beforehand that there might be some rashes which are not really harmful to the baby, and they are transient, they will go away. So this is another thing which you have to talk about. And then another thing which can happen is diarrhea. So sometimes these phototherapy lights may produce diarrhea, and then that is also quite normal. We have to tell the mothers. And then the requirement in the phototherapy machine goes higher, and the baby may go into dehydration. So this part is very important, because we have to tell the mothers that you have to feed more often, and you have to take care of the urine and the stool output to see the baby's hydration is well maintained. One, that dehydration is not good for the baby on the whole, but also the jaundice might increase because of this dehydration. So these are the some side effects which may be happening because of the phototherapy, which are very much preventable. And the thing is that we have to be taking care of those with the help of the mother and the nurse and us. The first line therapy all over the world, and especially the mothers, they asked, can I do give some medication? So unfortunately, that's not we have tried, but we didn't get a good answer. So the first line, if the baby requires some treatment, then it is only phototherapy. So we put the babies in. And then other thing which the mothers ask, can I, you are putting the baby in the light, can I do it in the home, in under some lights, I will buy and do it. Or the mothers would say, I can put it baby in the sun. So and the grandmothers and grandparents do ask for it. So I would say that you need a particular wavelength of the light, which should be breaking this bilirubin. So when you are putting the baby in the tube lights of the home, they don't have that characteristic, so it's not to be done. When you put the baby in the sunlight, it does have those wavelengths as well. And people have done lot of um, research on it, and they have found it does reduce the jaundice. But what happens is that there are, along with those wavelengths, there are toxic wavelengths also, which may cause harmful effect on the baby, and it may also cause a lot of dehydration to the baby. So that part is also out. So having said that, the only treatment, the first line treatment effective, would be your phototherapy, which is to be done in the phototherapy machines, which are specifically meant to give the wavelength of 425 to 480, which will break the bilirubin for the baby. So that will be the first line. Your second question was exchange transfusion. So nowadays, as I told you, that because of the fact that we are screening these babies, the time when I did my MD, we were doing exchange transfusions for many babies, and because the babies were coming from the peripheries. And but the hospital born babies, because we are screening those babies, it's very rare that the babies will go into exchange transfusion, because we are actually screening and calling them much before their for jaundice level goes to that extent. Having said that, some of the babies who are RH, and also for the RH incompatibility, the mothers now are being given treatment antenatally, so that we don't have RH incompatibility also. So these two things are going much down, but still sometimes you may have RH incompatibility or severe ABO incompatibility, where you may have to do exchange transfusion because the bilirubin levels have gone very high. Or if the parents do not have compliance and they don't come back to you, you still there, those are the babies, some of the babies whom you may have to do an exchange transfusion. So we do exchange transfusion in a baby whom we think that the jaundice level is actually reaching a level which was going to cause brain toxicity. So we want to bring the bilirubin low fast. So these are the babies whom we do exchange transfusion. So when we do an exchange transfusion, we send the baby's blood for the cross matching, and we arrange the blood. It takes time for the blood to come. So till that time, we will give extensive phototherapy along with the IV fluids. And these are the babies whom unfortunately we have to keep nil per oral, because we cannot give feed when we are doing an exchange transfusion. And then we wait for 2 to 4 hours to see if the bilirubin levels have come down or not. And by the time we will get the blood, so if it doesn't come down, we will go ahead and do the exchange transfusion. And in an experienced hand, exchange transfusion is quite kind of safe. However, still we should know that there could be some dangers if we do not do it properly, if we do it too fast, if we don't use a proper blood matching, then there could be issues when we are doing an exchange transfusion. So we have vast experiences. I don't know which one to share, but the main thing what we when I landed in this country, and we found that compliance was a very big issue. And babies will be born here, but then they will go anywhere, and then thing. So we might miss out on those babies. And we did miss out, and we did have initially exchange transfusions being done in our units. And sometimes even when we are not explaining the parents well, and they don't understand exactly, then also this problem has happened. So we try to do a quality kind of initiative studies to see how can we actually take care of these issues. And then we formulated that there has to be an education system to the mothers, to the parents, right from the birth. Need to give those pamphlets, and put IT into place, where they can give reminders, SMS reminders, and the phone calls. And if they still don't come, then again we held a nurse to call the parent to ask. It may happen that they may go to another clinic, but then we should know, and we need to document it. So these small things, and charting in the bilirubino chart, and putting it into the discharge summary, as well as in the the patient's card, where they fall into, so that in three places, so that these are the things which made us go very well control the jaundice, and give a proper care to these babies. And also we had a lactational, we didn't have a luxury to have a lactational consultant, but we had lactational nurses who were trained for it, who were really taking care of it, and teaching the mothers about lactation, because that's a plays a very important role. So these were the experiences which we had, and all these were stepwise. So it's not that it was from the day one. So, and it's a learning curve. We may still miss out, and we will be doing further things to really help these babies out. And of course, teaching the nurses how to do phototherapy, what to take care of, teaching the mothers during the phototherapy, and also teaching the residents, some of them who are coming from places who have never done exchange transfusions, to teach them all, is also another experience which I had here in this multicultural places.